disorders topics. Today we're hearing about the very interesting question of controlled drinking. Is it real? The science and the art. Thank you, Simon.
Good morning. I'd like to start by acknowledging the traditional owners of this land. My greetings to you, and thanking the APSAD conference committee for inviting me to this talk. I've come from Christchurch via Wellington, Rotorua, Auckland, so it's good to have made it to Adelaide in the end, and really enjoying this venue. Thanks very much. The topic I'm talking about today, I wanted to talk about this because I think some of you might think this is a little old hat, but controlled drinking is something that, or moderation and use is something that's been with us for a while, and for a lot of people it might feel like the debate has been done and dusted. But I think with that settling down, there's often not a lot of attention paid to exactly what the impact of those clinical judgments are in working with our clients, and the best way to do that. So what I'm aiming to do today is to have a blend of, I guess this is kind of translational research in a way then, isn't it? So have a blend of what the literature tells us, and talk a little bit, drawing on my own clinical practice and the way I teach around this too, around how to actually apply this. So this is the game plan for this session. If we go back to the earlier days of alcohol treatment, we were in a space for a long time where there wasn't really room for consideration of non-abstinent goals. As this quote from the AA Big Book kind of states in fairly firm terms. I want to make it clear that I'm not here to pick a fight with 12 steps. I guess I would pick a fight with anyone who wanted to suggest that one size fits all in alcohol treatment. But in fact, I'm very supportive of a 12-step philosophy. I encourage my clients to engage in it. It's one of the tools we have available. It suits some clients really well. Sometimes people don't know it's going to suit them until they give it a try, obviously. But we've got other tools in our bag as well. But for a long time, we didn't have those other tools quite so well developed, or it was difficult to at least give voice to those. Just in simplistic terms, the view was somewhat simplistic for a while there. If we sort of think of alcoholics as this severe, narrow group, and the rest of us, everyone else, some of this room will be the us, and some will be the them in that model. It's a fairly black and white view. There were some more nuanced views around for quite some time as well, particularly Jelinek work in the 1960s. So this is unfair to some of that other work, but predominantly and particularly in the treatment sector. This was how alcohol problems were viewed, and alcohol treatment followed from that. More recently, and this is the kind of slide would be more likely to put up in a teaching context, we've got a sense that actually alcohol problems come in a variety of shapes and sizes, and on a spectrum of severity. And so the treatment population is really this whole group here. This is the group who we're certainly thinking, hey, abstinence is almost certainly going to be what's required for you if you're going to have a good outcome. But we've got this whole large group of people where abstinence is either not all that appropriate, or only one of the options that people might want to consider. So how we moved from that first model to that second model wasn't a simple process. It sort of raged through the 70s and 80s in particular. During that time, there was denial that it was even possible for people really to control drink. That people who said they were doing that successfully were probably lying, or just weren't being followed up long enough. That literature that supported that was possibly being falsified. There were accusations along those lines. There were threats to funding sources and tenure. There was various divisions formed, in particular, I think, between the academic world and the clinical world. and particularly that's in the States where when I say clinical, it was largely and still to quite an extent is a fairly unqualified treatment sector with a lot of people in recovery sort of bringing their own experience and applying that to what they thought would work for everybody. And also to some extent between North America and the rest of us, so Australasia and Europe had a somewhat more liberal perspective around these issues. So it sort of came somewhat from within in the end. So the photos there, of course, are Linda and Mark Sabell, two Canadians who really had a substantial part to play in moving us forward. Relative peace broke out in the early 1990s. So Abstinence and Other Yardsticks of Success, in fact, is the title of one of their papers, where a more nuanced view around how we might conceptualise good outcomes was partnered with how we could actually engage with people around different treatment goals. Okay, so my title is Controlled Drinking. There are a range of different terms that can be used around this. I prefer controlled drinking because, as you'll see when I get to the sort of clinical application here, in a setting where people have relatively significant drinking problems and are going to try and reduce rather than cease, you do need it to be controlled is a little more defined, tied down, rule governed, rather than just sort of the broader moderation and low risk drinking type terms. So in that clinical setting, I like controlled drinking in terms of the general population. People at that milder end who maybe are just drinking a bit much, talking to them about education around low risk drinking rather than controlled drinking would be more suitable in that context. But I'm largely focusing in a clinic type setting here with today's talk, and favour that term for that reason. I'm going to have a look at how popular controlled drinking is, both from a workforce point of view and from a client perspective. Range of countries here, just looking across a wide range of services around the sector. And it depends on what question you ask here too. Whether or not controlled drinking is suitable for anyone, for most people, is whether or not it's something that you use in your clinic or not. So different questions get asked, and the slide's a bit of a simplification. But what we can generally take from these figures is that, not surprisingly, there's a tendency to be more reluctant to consider moderation for greater severity, and that's both in terms of dependence versus abuse, and most likely inpatients versus outpatients. The fact that those alcohol abuse figures aren't 100% or very close to 100% in terms of moderation suggests, there really is quite a prejudice against controlled drinking in a lot of places. Those figures of 55 to 80% still are, I would argue, are relatively low. There's also that difference between the US and elsewhere is evident if you contrast across those figures. Some Australian data here. So these are both 15 or more years old. Bear this in mind. So two different studies published around the same time. Both had actually the same number, I think it was 171 services, two different studies, 171 services in Australia in the same year. I know Nick Heather and Sharon Dorr did some work together, but they may or may not have talked to each other around these two studies. And there are sort of some similar figures to what's found with the slide earlier. So 2/3, 3/4 of agencies had some support for controlled drinking. It tended to be higher in the outpatient settings. Donovan and Heather also looked a little bit about individual clinician characteristics. The more qualified you are, the more likely you are to be accepting of moderation goals. And I think that's at least in part going to tie into those two pathways into our workforce, people who come via university versus those who come via the University of Life and their own recovery. Okay, so we don't have I don't have exactly the same data for New Zealand, but we do have this this study. We did a national workforce survey. So we interviewed 231 people in the addiction workforce, which at the time was about a quarter or more of our workforce. We've grown quite a bit since then. In this case, I'll just highlight the key sort of drinking figures there. So Rachel's drinking 40 or 50 standard drinks a week. That's about a bottle of wine a day, every day. Moderate alcohol dependence, no alcoholic liver disease, no withdrawal syndrome. The scenario was chosen to be kind of in the grey area where people might have different opinions over whether controlled drink or moderation, whether controlled drinking or abstinence was really the best goal for people. And we asked our clinicians, what drinking goal would you think is best for this person, just as an open question, and we had some set categories, and we then discussed with them based on their open answer which category best defined them, which are all of these. And just to highlight then, we've got about a third who thought an abstinence goal was most appropriate, and about 2/3 who went for a non-abstinent goal. For what it's worth, my clinical judgment is I would like to see Rachel abstaining based on those figures. I think she would have a hard time controlled drinking, but she's definitely in the category of people who may well want to moderate rather than stop, and I'd be quite comfortable working with her and trying to achieve that goal. I'm preempting about what I'm going to talk about in the clinical application, but and there's no right or wrong answer with this. There'll be different opinions, but I'm just going to share mine since I'm sharing all these other people's opinions at once. We then also asked, well, what if Rachel also had a co-occurring current depressive disorder? And I think we might have provided a hint that there could be a substance-induced element to it. I'm not sure. And what we essentially found is a bit of a migration more towards abstinence in the population. I was a bit concerned with these figures too. Just look at these for a moment. When you look at the continued use, to half of current consumption, which is still quite a lot of drinking, or reduction without any clear goal, that's about 20% of people had a really loose idea of what controlled drinking was. So just another pointer as to why I'm giving this talk, why I think actually we don't necessarily do this all that well a lot of the time. Okay, in terms of how popular controlled drinking is in client populations, there's no simple answer to that because it really depends on which client population you talk to, and essentially the more severe people's drinking is the strongest predictor here, but it really just varies depending on the client, the characteristics of that particular group. Two studies though that I'm going to talk about a bit, and I'll be back to in a slide or two, that I thought I'd just highlight. A New Zealand study, the brief treatment program, mild to moderate alcohol dependence, 2/3 chose that as their drinking goal. The UK alcohol treatment trial, a somewhat heavier drinking population, it was just under half. So you've large proportions of our client population actually want to moderate their drinking, is the take-home message from that. Okay, so which characteristics predict choosing controlled drinking? So I'm just going to describe these two studies because I'm going to come back to them again also when I look at outcome. So the brief treatment program, my boss Doug Selman and I ran this in the 1990s. It was an RCT of motivational enhancement therapy compared to two other treatment conditions. We asked people what their drinking goal was at intake, at the end of the 6-week treatment period, and at the 6-month follow-up. And yeah, that's probably enough information about that. So there were quite a range of predictors of who chose a moderation goal, but when we did a regression analysis to sort of thin the field down a bit, these are the key things that come out. People who drink more frequently are more likely to be controlled drinkers, which might seem slightly counterintuitive, but frequency of drinking isn't necessarily a great measure of heaviness of drinking. And we sort of get a bit of a split there between frequent lower drinkers and more episodic heavy drinkers. So it's the person who has a bottle of wine a day or something like that who would like to just dial it back rather than the person who goes on binges that kind of start unpredictably, who thinks I'm going to have to stop if this is ever going to change. Fewer alcohol related problems and being less motivated, having less less intrinsic desire to change. This was at the end of, we're looking at predictors of goal here at the end of treatment, and the population who were assigned to motivational enhancement therapy were more likely to choose an abstinence goal, and those in the other two groups were more likely to, in relative terms, to choose a non-abstinent goal. Okay, and then the UK alcohol treatment trial. This was a large study, 742 people presenting to routine treatment services in a range of settings around the UK, England and Wales. They had no exclusions around severity. They really wanted a typical population. They were comparing motivational enhancement therapy, as we did in the BTP, and social and behavioural network therapy, and many of you will be familiar with this study. It's not the best measure of drinking goal. It was done at baseline, and the clinician just wrote down themselves what they thought the patient's drinking goal was. Now, in order to do that, in most instances there would have been a direct question asked, but it wasn't collected explicitly in that way. So there's room for a little bit of clinician projection about appropriate goals here. So just a caveat around that. An outcome was measured at 3 and 12 months. So that was just baseline goal pre-treatment. Obviously this study was better powered to detect predictors than our study of 122 people was. Males were more keen on controlled use. Again, they found more frequent drinking, and also added to that less heavy per drinking occasion. So it's my comments there about that sort of steady state drinking kind of pattern. They didn't require detoxification. We just took that as a proxy for severity of dependence, which I think you'll agree, and greater social support for ongoing drinking. If you're in a context where people were hostile to you continuing to drink, you were more likely to choose what those around you thought as well. Okay, now importantly here, what's the impact of this on outcome? In Rose's introduction, she mentioned my PhD work. This was a systematic review of reliable predictors of treatment outcome for alcohol use disorder, and the robust predictors there were the predictors that were consistently predictive of better outcome in studies that also controlled for a range of other strong predictors of outcome. So studies that did regressions that included a bunch of these things, and these are the things that came through. So abstinence as an abstinent drinking goal was a robust predictor there. It was almost in the tentative group just because there weren't very many studies. There've been a few more since, and they've been consistent in that finding. But it was interesting to note, compared to these other predictors, just how few studies actually take the time to ask people, what is your drinking goal, and use that as one of the predictors of outcome. It's clinically such an obviously important thing, and yet our research doesn't seem to be reflecting that. Okay, so for the brief treatment program, we categorise people into these four groups. Controlled drinking was sticking entirely within our recommended national drinking guidelines, and then there were two levels of increased use above that, hazardous and unequivocally heavy. And we had a strong difference between those choosing abstinence and those choosing controlled drinking at the end of treatment as a predictor of 6-month drinking outcome. What we did though as well, and to date this is still the only study that's done that, is we didn't just ask people which of those goals they had. We asked people what they meant by controlled drinking to define that for themselves. The studies that are out there tend to either kind of fudge this slightly or provide you with their definition, which is what they would try and work with clients to do. But you can educate someone about what controlled drinking might be, and the idea that there's one level that fits everybody, I'm going to argue with anyway, but it doesn't mean that people are going to follow that. So we did educate people about our national drinking guidelines. This is what they were in the 1990s. They've changed a little since. So per session and per week figures there. And then we asked people, well, what level would you like to choose? And there's probably a bit of a demand characteristic there that some people are just going to say numbers that stick with what we want because they think that's what we want to hear and it won't necessarily reflect their goal. But we had quite a few people who were comfortable suggesting a goal that was higher than that. The figures varied and people moved around a little bit from baseline to 6 months. So quite a few people, as you can see, were choosing a goal above the recommended guidelines. So it's the drinking goal at 6 weeks that we were using as a predictor. So over 40% had chosen a goal that was higher than that. And that could, one young man comes to mind who decided to reduce. He was only going to drink 20 standard drinks per occasion was his controlled drinking limit, but he was only going to do it 2 days a week, which was a significant improvement on what he used to do. But it's probably not most of our definitions of moderation or low risk drinking, but it was a reduction goal for him. The key point with this then is if we divide the controlled drinkers up into those who are controlled drinking at a level that looks, somewhat appropriate or, relatively low risk, and those who are setting limits that are above that level, we get quite a separation occurring, and there's no longer a significant difference when you compare the within guidelines and the abstinent group. If I show that graphically, so that's all of the non-abstinent people. The top two categories are the good outcomes, abstinence and controlled use. And when you split out this non-abstinent group into those two, most of the poor outcomes are in that heavier group. Now, I've just said in the last slide that these two groups are not significantly different. Now, eyeballing it, intraocular analysis will tell us that it looks like there is a difference, but the study is underpowered. I think if we had more power, there would be a difference. Yeah, so I think it's worth acknowledging that. But these two conditions are substantially more alike one another than these two are like one another, and all the other controlled drinking studies just simply lump those two right-hand categories in together. Abstinence is a really clear concept. When someone says, I'm not going to drink at all, we know what they mean by that, and we know how to measure it. But when people say, I'm going to moderate my drinking, they can mean a whole wide range of things, and to think of them all as one group of people, I think, is simplistic. And the research is still being simplistic around this. Okay, so we were interested, so clearly not just whether or not you choose controlled drinking versus moderation was controlled drinking versus abstinence was a predictor of outcome. What kind of controlled drinking you chose was important. We looked at what predicted those controlled drinking goals, and again there were a range of things in univariate analysis that were significant, but when you put them into a regression, only one factor was predictive, and that is age. Younger people don't want to reduce down to something like the national guidelines. It just sounds too little to them. Older populations are far more likely to think, yep, I'm okay with going with that. Okay, drink goal and outcome in the UKATT study. Okay, so at 3 months, what we did first of all was we categorised people into the pie there, into recovery and non-recovery. Recovery was defined as either abstinent or continuing to drink with no alcohol-related problems. And what we find is there's a significant difference between groups. Those who choose abstinence have more people who reach recovery status. And when you look at how people achieve that recovery, the way in which they've achieved their recovery matches what their goal was to quite a significant degree. But note that in both cases there are people who said they were going to control drink and ended up abstaining, and there are people who said they were going to abstain and ended up being non-problem drinkers. Fast forward to 12 months and the gap closes in terms of recovery status. There's no longer a significant difference. There's a trend, but it's a big study, so 700 odd people, so they're not really all that different in terms of achieving recovery. Still a difference in what their goal is, but in both groups there's an increasing number of people who are actually abstaining. So as people go through this process, they tend to migrate over to abstinence as the way in which they achieve good outcomes. And there's a growing number of people who are in a recovery category at follow-up also. We also measured percent days abstinence and drinks per drinking day, and we found, again, well, at 3 months we found they were both had better outcomes with the abstinent goal group, although it was a fairly slight effect for amount consumed per drinking day. And at 12 months, that one was no longer significant. When you control for the predictors of drinking outcomes, I've already highlighted that there are, we're not randomly assigning people to each drinking goal, right? So there are different people who choose abstinence to the kind of people who are going to choose controlled drinking. They have different clinical profiles, and when you take those profiles into account, there tends to be a reduction in the apparent causal relationship between drinking goal and outcome. Those things reduce, although percent days abstinence, it stayed pretty robust. That was still a fairly strong one. Okay, so just conclusions around the literature there. So drinking goal an abstinence drinking goal does predict better outcome, but those people choosing abstinence are a different group. They're more motivated, they're more aware of the negative consequences of their drinking, and people around them are more supportive of abstinence and less comfortable with moderation. So they've got various other things on their side already. Some of those outcome measures aren't different, and some of them are relatively slight. Which goal someone chooses isn't just based on what the outcomes show. We've got to think about about engaging people and what they want, and we've got a significant proportion of people who don't want to abstain. We need to bear that in mind. When we talk to people about drinking goal, it's not just the one question. We've got to go into what they mean by that, and hopefully have a positive influence on how that's shaped up, which is what I'll get to. And so positive outcomes generally matches the choice that people make, but not always. People can end up doing different things. So I don't think the data suggests that if I've got a client who decides to abstain, I'm encouraged by that. That's prognostically positive. But if they don't, I'm not going to argue with them about it. I'm not going to believe that necessarily means they're going to have a poor outcome, but I do have this information to be able to provide some education to my client. Are you aware, or to let you know, etc. In terms of them coming to that decision. So it's informative to have that. Okay, so this is my version of how to work with people around controlled drinking. So thinking about why we do that, I provide controlled drinking because often that is what someone comes to me wanting. We want to support the autonomy of our clients to make their own decisions in their own lives, and sometimes they don't want to abstain. They just want to reduce. If I only have one option, I'm not meeting their needs. They're going to be better engaged with me if I'm able to provide that. There isn't any literature around, the study we'd like to have is a study that, compels one group of people to a set treatment goal and gives other people the choice, and there's a few questions we can answer by doing that. And one is whether or not actually giving people the option makes a difference, and we know that in some other areas, and the example that comes most readily to mind is the great NEPOD studies that have been done here around opioid substitution. The mere fact of people having some choices in what kind of treatment they receive tends to improve outcome, whichever choice they end up choosing. So choice tends to be a good thing. And we want to titrate the intervention to problem severity. It just doesn't make sense that we'd have the same goal for everybody, because alcohol problems come in a wide range of severities. The people who are at that mild end are very unlikely to want to abstain. Sometimes they do, but they're very unlikely to. The people at the severe end sometimes are not going to want to abstain. There's a larger group of people who don't want to abstain in the severe end, and then there are people who do want to abstain in the mild end. But you do get people generally making choices along that spectrum that's appropriate to where they are. And controlled drinking, even if it doesn't necessarily work out for someone, that hasn't been a waste of time. People learn about themselves and about their drinking and what they need to do in that process. If we need to bear in mind, though, that supporting people with what they want is I think is appropriate, but there is this kind of awareness in the back of our heads that not all choices are equal, and a better choice in terms of prognosis would have been to choose abstinence. So that's on a population base, and just with an individual person in front of you, sometimes there's a sense that I struggle sometimes a little bit with clients where I just feel that I'm selling them short, and that this person would really benefit a lot more from abstinence with what's going on in their lives. But it's a process, it's a process that we work through. But I think it's healthy to bear that in mind. And there is probably an increased risk of relapse with moderation. I mentioned before that abstinence is really clear. People know what it looks like, and they know as soon as they do something non-abstinent, it's really apparent. Any drink of alcohol is non-abstinence. Whereas with controlled drinking, and I'm particularly thinking post the treatment period here, people can just slowly just kind of move off track, and they make an exception for this, or they don't count that, and it can just kind of build up a head of steam before you realise what's happening. That's harder to do with abstinence. So I think controlled drinking has its challenges around that. I always ask people what their goal is, but I'm always happy to share with them what my clinical judgment is and my opinion as to what is most likely to suit them, and then talk through with them what they're going to choose in light of that. The things that are most relevant, of course, to whether or not controlled drinking is appropriate is level of severity, and the most salient part of the dependence criteria are the discontrol ones. People who tend to drink too much once they start drinking are the ones that find it harder to moderate than the ones who actually just drink a lot because they chose to, and they might have some more choice around that. And the other severity factor there is, what are the impacts of someone's drinking? If someone has a major mental illness, physical health complications, domestic violence that is often facilitated by their drinking, abstinence is starting to look a whole lot better for that person. What have they tried in the past? Has it worked? Obviously it hasn't ultimately worked. They're talking to you about their drinking, but has it relatively worked? What is the support for moderation around them? Bear in mind that's a predictor of outcome, and I think that's that's important to remember. And also just a practical issue of a suboptimal drinking goal, but actively engaging with someone in treatment is better than them walking out the door because you're not able to offer what they are seeking. So that's the ultimate test there. And sometimes people are going to want to moderate their drinking when it just sounds like a complete disaster waiting to happen. It seems completely inappropriate. You've got to be kidding. But we can have clear guidelines around these things, but people are always able to surprise us, and even people at high severity can occasionally, very few of them, actually have a successful outcome with moderation. So I wouldn't think that your chances are zero if someone really doesn't look like moderation is going to work for them. I think the chances are low, and that's not zero. If someone, the guy I mentioned before, he's cutting down to 20 standard drinks, doesn't sound like a good outcome in and of itself, but if that's a reduction from what it was before, then of course it's a good outcome. That person drinking less often and a lesser amount is going to have fewer negative consequences for those and those around them if they do that. Controlled drinking can be a step towards accepting that abstinence is what they need to do for some people. Or a step toward, it's once they might start to make some changes and you're engaging with them, they might choose that abstinence goal, or a slightly different path to the same outcome is by trying it and it just not working at all. That's where someone figures out for themselves, in a therapeutic context, that controlled drinking is not a viable solution for them, and then they adopt an abstinence goal, and they've learnt that from experience with your support rather than being told it. Choosing a limit. In the BTP study, so we just had the national drinking guidelines that we used in that study. So of course the first thing is defining what a standard drink is. We have the same definition in New Zealand as you do here in Australia. Helpfully most beverages have it printed on the bottle now, which makes our jobs a lot easier. Our figures have reduced a little from what they were. So we've got an average per occasion over time, long-term consequences, and an amount per drinking episode in terms of intoxication effects, somewhat similar to the figures that you have here in Australia, so 4 drinks on a single day. So we've retained the gender distinction. You guys have gone for simplicity of message, and I think there are probably a couple of other good reasons for doing that. But anyway, we've got slightly different figures. So are those figures aren't designed for clinical use with people with alcohol dependence who are trying to moderate though. They are low-risk guidelines for the general population in terms of drinking. So it can be argued those figures are they're too low for someone, the young guy reduced to 20 drinks. Those figures just sound ludicrous. Why bother drinking if you're only going to have 4 or 5 drinks? Is probably the kind of thing he might have said. But equally, well, more than equally, I would argue actually those figures probably are too high for someone who has a propensity to get in trouble with their drinking. Those figures are for the general population who are just going to try and balance their drinking with health and other things. If we're looking at people who've got into trouble around alcohol, I would look at those national guidelines as very much which way are we going? This way. As a maximum figure, and lower would be better. Actually, I don't recall from the Australian figures, but so in New Zealand we have a recommendation of at least 2 alcohol-free days per week as part of our guidelines. When someone is reducing from problematic drinking, I would certainly want to see a much higher proportion of non-drinking days as part of that picture. And then in terms of the actual figures, it's good to so talk to them. Obviously, the first thing is what level of drinking can lead to trouble. So what's unhealthy for you? What leads to intoxication-related negative consequences? Where does your behaviour get unreasonable for those around you? And at what level are you going to feel, poorly the next morning and impact on your work and so on. But there's also the level at which they start to lose control, because obviously if you get into that zone, then whatever the number was might go out the door, and you've got to stay below that level. So if you think we're not just aiming for someone to stay in a low risk category, they need to be, low risk isn't just short of being, less more than low risk. They need a reasonable amount of headspace to not cut that too fine. So obviously we'd sort of nail down what most of the literature talks about contracts here, a drinking contract or a treatment contract. I never use the term contract. And it just sounds awful to me. So we just talk about rules or parameters for drinking. I also often talk with people about, are you happy calling this controlled drinking, or would you like a different term? Because some people that just pushes all the wrong buttons for them. We don't want to push people's buttons. Often people are fine with that, but quite often they're not, and they choose another term that works for them, like social drinking. LSD was one that one of my clients thought was quite witty and sort of ran with that. So as part of that non-contract, being a psychologist, of course, I'm always scribbling on a whiteboard with my clients. Smartphones are a wonderful invention, and everyone's got a camera in their pocket now as well. So we sort of nailed down how much is a maximum per occasion, per week or sometimes per fortnight, to give people a little more flexibility of when they can kind of use their drinking days. And you've got to define when a week is, so it's quite clear when you start counting, and you don't want ambiguity around these things. Sometimes people set a rate of drinking as being just as important or more important than the total amount achieved. And the do's and don'ts list is where probably most of the time gets spent. So So, and these next few slides, these are all things that are that I've scribbled on the whiteboard with my clients over time that they've suggested or I've suggested. I always start with their ideas and start to throw a couple more and just see if they fit as well. Yeah, so having one sometimes, that's a nice one. It's a real change in your relationship with alcohol that you might actually have a drink and stop at one because you set a limit, and if a lot of people will tend to go for the limit means they'll drink up to that every single time they drink. I can have 4 drinks, I'm going to have 4 drinks, and they do it every time. But just having one just starts changing that relationship around alcohol. Keep a diary. It's obviously good as part of the treatment process to see what's happening, but that self-monitoring awareness of consumption is really helpful. Taking your time enjoying it, spaces, so non-alcoholic drinks. Yep, so and a couple of other points there. The don't list is longer than the do list. Is that my 5 minutes? Right. Don't stay out after 1 a.m. Nothing good happens after 1 a.m. is what one of my clients wrote. And I don't know if he got that from a public health message or not, but it's a great public health message, isn't it? Nothing good happens after 1 a.m. And it's the thing you've got to kind of remind yourself before you go. There's conference dinners tonight. I think we're all professionals and getting older, so we should probably put another digit on that and maybe change it from AM to PM. But anyway. But again, that's an individualised thing. For some people, that's completely irrelevant. Rachel, who drinks about a bottle of wine at home, or she's drinking casks. Someone who drinks at home, that's just not relevant. For someone who goes out into town with their mates, that's the big thing that they might want to change. Don't drink in response to negative emotions, and stay off particular drinks. Red Bull and vodka. So again, that was a specific example from a specific client. That was the kind of drinking that he did when his drinking got into trouble. And you could argue the cause and effect around that one, but he knew that he was heading in the wrong direction once he started doing that. Don't preload is pretty obvious. And with the kind of drinking level that people typically set here. Preloading's not often an issue. I should have said too, with my clinical experience, I talked about that, the ALAC guidelines and so on. The levels that people tend to set for themselves, in the vast majority of cases, people do comfortably set a level that's well below that. They'll be looking at 2 drinks, so maybe 2 drinks, 3 or 4 drinks in that range. Once or twice a week, that kind of frequency. Sometimes, I do get people who push that out a reasonable amount more, but the great majority are actually going for relatively modest figures here, and that's across a relative range of severities. So you don't drink before dinner, while cooking, or after dinner. Clearly, those relate to different clients. You wouldn't have all of those. That's called abstinence if you have all 3 of those rules with one client. But again, it's sort of getting into that conversation with people about how their drinking has worked, how it functions, when it starts getting into trouble, what a different pattern would look like that's going to work in their lives. Yeah. So if you break a rule, which doesn't inevitably happen, but it's happens half the time, you want to have a plan around that. So share that information, work out what's happening, have some time off, kind of as a penalty, but as also kind of a reset thing. It makes it harder to decide on bugger and I'm just going to have an extra one. If you realise there's a cost attached to that, there's a little bit of a balancing that goes on with that. But before we get to, I'm about to be shuffled, before we just quickly go through the last few slides here, before we get to that moderation level though, there's an important phase first, and that is the first step for a good controlled drinking plan is actually to abstain for a period, to have a break. When I started working clinically, I didn't used to do this. We just kind of move it down, and it really just didn't work as well as having a break first. And I tend to go for the longer period, the more like the 3 months rather than the 1 month. But it's more a matter of what I can get away with really with my client, what they're willing to do. It's a great experience for people. It's a chance to see what life's like without alcohol, what it's like getting home from work without having something to drink routinely, going to functions. It's got to be long enough they get exposed to a range of experiences. They can't just be a hermit, or it can't just happen to be a month where there weren't any parties they went to, or they weren't out of town with work, that kind of thing. They get to develop new skills on how to do that. It just starts to feel normal not to have a drink, on occasions where they just wouldn't have even considered not drinking before. And one of the really nice things with this is when we get to the end of it, I don't assume that they're still really gunning for moderation. We'd sort of initiate the abstinence period and we'd have the discussion about what moderation looks like during that time while we're doing some other work. But sometimes when you get near the end of it, a client might decide, I don't want to put it, this has actually gone better than I thought. I don't want to put my positive changes in jeopardy by reintroducing some alcohol. Now that I've had this experience, it doesn't feel worth the risk. So sometimes people just stick with abstinence, which is really nice. And then, once we've had the break and set all these rules, we develop skills, monitor progress, make changes as required, and engage family. So finally, lots of our clients want to moderate. Abstinence does predict better outcome, but that doesn't mean prescribing abstinence would do the same. Controlled drinking is appropriate for a lot of people, and hopefully I've given you an outline of what doing that well looks like. Thank you.